One of the greatest mistakes medicine keeps making is confusing the limits of our technology with the limits of reality. Those are not the same thing. History is littered with diseases physicians once dismissed, not because they didn't exist, but because we simply lacked the tools to see them. Peptic ulcers, Helicobacter pylori, prions, hepatitis C. Even Lyme disease remains notoriously difficult to diagnose accurately in many patients despite decades of research. I believe Crohn's disease may be the next chapter in that same story. There is an intestinal disease of cattle called John's disease. Veterinarians don't argue about what causes it. It is caused by Mycobacterium avium subspecies paratuberculosis, MEP. The pathology looks remarkably like Crohn's disease in humans. Chronic granulomatous inflammation of the intestine, difficult to eradicate, waxes and wanes. The obvious question has been asked for decades. Could MAP also contribute to Crohn's in people? Medicine's answer has mostly been it's an autoimmune disease. But what does that actually mean? A recent multi-center study from India looked at nearly 900 treatment-naive patients. They searched for MAP using antibody testing, tissue PCR, quantitative PCR, blood PCR, tissue culture, and immunohistochemistry. Some methods found significantly more MAP in Crohn's patients than in ulcerative colitis, intestinal tuberculosis, or healthy controls. Other methods did not. The authors concluded there is an increased association between MAP and Crohn's disease. That's a reasonable scientific statement. Yet many clinicians will read the same paper and walk away thinking,
still controversial, case closed.
We keep asking the wrong question. We ask, can we find the organism? We should be asking, how good are we at finding the organism? Those are completely different questions. If a pathogen is hard to culture, lives inside cells, exists in very small numbers, forms biofilms, or is unevenly distributed in tissue, then a negative biopsy may simply mean we sampled the wrong spot. Negative does not automatically mean absent. It often means undetected. Medicine understands this principle in other diseases. We somehow forget it when the organism is MAP. Years ago, I became interested in persistent chlamydia infections. Patients with long-standing disease frequently tested negative despite clinical pictures that strongly suggested ongoing infection. The problem wasn't always the organism. The problem was the sensitivity of our tests. A negative result cannot exclude disease when the test itself is limited. We didn't find MAP is not the same statement as MAP isn't there. We treat those two sentences as if they mean the same thing. They do not. In my own practice, I have treated patients with inflammatory bowel disease using multi-drug antimycobacterial regimens. They improved. That does not prove MAP causes Crohn's. Anecdotes never prove causation, but repeated clinical observations should create curiosity, not dismissal. Medicine advances when physicians notice patterns before the science fully explains them. Here's the question that won't leave me alone. If MAP contributes to Crohn's disease in even a subset of patients, and if our current tests cannot reliably rule it out, why is so much of modern treatment focused almost exclusively on suppressing the immune system? Immunosuppressive drugs can be remarkably effective at reducing inflammation and improving quality of life. They matter for many patients. But if an infectious trigger is driving disease in some people, then turning down the immune response without addressing that trigger raises a serious question. Are we treating the fire while leaving the embers? That question deserves careful study, not institutional shrug. Not long ago, medicine taught generations of doctors that peptic ulcers were caused mainly by stress and excess acid. Then 2 Australian physicians suggested something almost heretical, a bacterium. They were ridiculed. Today, Helicobacter pylori is accepted as a major cause of peptic ulcer disease, and antibiotic treatment has transformed care for millions. History does not guarantee that MAP will prove to be the answer for Crohn's, but history does teach something else. Medical consensus is not infallible. Sometimes our diagnostic tools lag behind biological reality. Perhaps MAP is a primary driver in some patients. Perhaps it acts only in a subset. Perhaps it works together with genetics, the microbiome, environmental factors, and immune dysregulation. We simply do not know, but uncertainty should never become an excuse to stop asking better questions. The purpose of medicine is not to defend today's consensus. It is to discover tomorrow's truth. If our current tools cannot reliably detect MAP, our first response should not be complacency. It should be to build better tools, because the absence of evidence is only evidence of absence. When we are confident, we would have found it. Right now, I am not convinced we would. I have also treated several IBD and Crohn's patients with hyperbaric oxygen. HBOT may help not only by reducing inflammation and promoting mucosal healing, but because it may enhance the host's ability to control intracellular pathogens such as MAP. If an infectious organism contributes to disease in a subset of patients, then therapies that improve the body's ability to control intracellular infection, whether antimicrobacterial drugs, optimizing immune function, or hyperbaric oxygen, might be expected to converge on the same clinical endpoint, healing. The fact that very different approaches sometimes produce similar improvements should not end the conversation. It should start a deeper one.